A very good afternoon to one and all. Without delay, we'll start the presentation. So the topic is Keratoconus Unveiled, Navigating the Latest Advances. So we will be covering the latest things in keratoconus risk factor, pathophysiology, diagnostics, therapeutics, and also a final talk on all this um, comprising of a future research kind of a talk. So our speakers are, the initial talk will be by Dr. Nadna Bashir. She's consultant cornea, cataract refractive at RE Eye Care Thrissur. She has done her cornea fellowship from Shankar Netralaya. The next talk is diagnostics by Dr. Sharath. He has done his MD from RP Center AIMS and did 3-year SRship in RP Center AIMS itself. And he's currently working as cornea cataract refractive surgery consultant at Chaitanya Hospital, Eye Institute, Trivandrum. Cornea collagen cross-linking will be covered by Dr. Jairam VR. He is the medical director and chairman of Precise Eye Care, Trivandrum. He has also done his post-graduation and further residency from RP Center AIMS. The next talk is on surgical management of keratoconus by Dr. M. Vanati. She's professor of ophthalmology, RP Center AIMS, and currently serving as editor IJO. She's well-known cornea person nationally and internationally. The final talk will be by myself, Dr. Nimiraj. I'm also a postgraduate from AIMS RP Center and have done my senior residency from the same institute. Thank you. Now going on to the first talk, I invite Dr. Nadna to start, please.
Good afternoon. At the outset, I would like to thank Dr. Nimi for giving me this opportunity. So the topic I'm going to present is Rising to the Challenge, Understanding Keratoconus. I'll go through a small introduction, epidemiology, etiology, pathophysiology, clinical features, classification, and when to screen, and a short note on keratoconus in pediatric eyes. So we all know keratoconus is derived from a Greek word which is kerato means cornea and conus means cone. And by definition, it's the most common primary ectasia of the disorder, primary ectasia of the cornea with bilateral, asymmetric, progressive steepening and thinning of cornea, which results in irregular astigmatism and visual impairment. Coming to the epidemiology, in a recent study with a meta-analysis done in along 15 countries, they found out the global prevalence to be around 138 per 100,000 population. And a newer study from US where they used sensitive tomography, they found the prevalence rate to be around 1 in 375. In 2024, a study from the LVPI, they have found the prevalence to be around 0.62%, and they have also noticed that prevalence was much common in children less than 16 years. It's a disease of the second decade, that's adolescence and early adulthood. So this study from the LVPI, they found out in their study the males had a preponderance, and they also found out that upper middle socioeconomic class and the upper socioeconomic classes had more keratoconus. Professionals were more having risk of keratoconus, and as the decade passed on, that increased the risk for keratoconus. It's a bilateral disease and asymmetrical. Usually 40% present as unilateral. And when we look for changes in the other eye, usually they starts with a subtle signs, and more common in the Middle East population. So we know that the most common major and modifiable factor is the eye rubbing. So constant mechanical trauma, either by eye rubbing or due to some use of contact lens, can cause micro trauma, which cause increases in the enzymatic degradation and thus cause ectasia. Another common etiological factor is a family history. Always we look for family history for glaucoma and retinitis pigmentosa. Also always ask for keratoconus history in family, because it's around 15 to 67% high risk for developing glaucoma with a family history. And when checked, familial KC is more autosomal dominant, and it is associated with a chromosome with 5. Overall, KC is due to environmental triggers in a genetically susceptible people. Other etiological factors like systemic association with collagen vascular diseases, which is the Ehlers-Danlos syndrome, osteogenesis imperfecta, Noonan syndrome, all these can have a chance for keratoconus. Especially in Down syndrome, children always tend to rub the eyes, so that patients are more prone for keratoconus. Coming to pathophysiology, as already discussed, keratoconus was thought initially as a non-inflammatory disease, but now recent evidences are showing it has more of inflammatory pathology. So other than that, keratoconus formation is due to mechanical weakness, and the protein signaling pathways also show that altered expression, that CD34 levels in keratocytes have been seen to be reduced, and increased in laminin and fibronectin in the scarred areas, which says that this is a dysregulated wound healing which is happening. Other than that, oxidative stress also plays a role, that increase in the reactive oxygen species, reduced in the ALDH3 enzymes, and most importantly, the enzymatic activities using increase in the proteinases and reduce tissue inhibitors of proteinases all cause stromal thinning. And the damage gradient in the corneal apex, they are more prone to stromal thinning rather than the periphery of the cornea. Clinical features in the early stages, it can present as blurred vision, monocular diplopia, halos, glare, frequent changes of glasses, not happy with the having a contact lens, and in case of an acute eye drops, it's always sudden drop of vision and painful visual loss. So the disease progresses till 4th decade, and thereby it stabilizes. So these are the various signs which we are associated with keratoconus. This is all named signs. So this is the Charloy oil droplet sign seen in the retinoscopy, retroillumination. And also this is the scissoring reflex. That is, it moves like arms of a scissor in case of a irregular astigmatism. Then the Fleischer's ring, which is one of the classical feature of keratoconus. Then this is the Vaux striae, which is the posterior stress line which disappears on pressure. And another most common feature is the Bowman's layer scarring. Scarring in the anterior stroma due to tears in the Bowman's layer. Advanced KC, we can see the Munson-Stein, which is the V-shaped indentation of the lower lid in downgaze due to the prominent cone. And for this picture shows the acute eye drops where the cornea will be seen as fully edematous. So basically, the keratoconus and pellucid marginal degeneration occurs. We just differentiating between pellucid marginal and keratoconus. It's that inferior temporal thinning in the case of keratoconus, and then in the pellucid marginal degeneration, there is an inferior 1 to 2 millimeters band of thinning, and the ectasia is usually above the area of thinning. These are the various classifications, and now I'll just give a short note on whom to screen. Always with a patient with a history of atopy, VKC, atopic keratoconjunctivitis, allergic conjunctivitis, take a K reading, and on routine examination, when we find the K reading of more than 48 diopter, try to do a corneal topography. And patients with high irregular astigmatism, and the patients with recent onset of refractive error in the first decade or in the second decade, or a patient with a family history. Keratoconus in pediatrics, just a short note, it's a more aggressive disease, it progresses rapidly, so the close follow-up is essential in these cases. Coming to the take-home message, keratoconus is a progressive corneal ectasia with conical protrusion. Etiology is multifactorial. Early diseases can appear clinically normal, and timely intervention can prevent progression and preserve vision. Thank you.
Good afternoon, everyone. I'll be dealing with the innovative diagnosis, the future of detection in keratoconus. there is no financial interest. Why do we need a better detection of keratoconus? As she described, there is a rising prevalence in the keratoconus patients, especially in the Southeast Asia and the Middle East. And there is a refractive surgery boom, so we need to detect all cases of keratoconus, especially the subclinical cases, to prevent any post-refractive ectasia. And the goal has shifted from identifying disease to predicting risk factors. So in the diagnosis evolution, we have in the first description of staphyloma diaphanum, we have moved across to the Placido disc methods, to the computerized team flux imaging, to the Corvis ST bad displays, and finally in the new era of AI and multimodal imaging in 2015 onwards. So the traditional imaging by Helmholtz-Schwartz, they were able to detect the distorted mild steep cornea and the high astigmatism, but the limitations were they were measuring only the 3 to 4 central mm of the cornea, and when the keratometry exceeds more than 55, they could not detect any cases of keratoconus. So as in the first case, you can see that these are the cases which we like to miss on a clinical slit lamp examination. These needs advanced imaging techniques. So corneal topography or tomography techniques include the Placido-based ones, the Placido disc, video keratography, the slit scanning system, the OpScan, seam flux imaging, the Pentacam, Cirrus, and the Galili. So what is the difference between tomography and a topography? Topography just analyzes the surface shape and the features, whereas the tomography gives a three-dimensional imaging of the cornea. So these are the conventional topographic screening parameters. I'm not going to into details of these parameters. So we'll move on to the OpScan. OpScan is based on the slit scanning technology. OpScan 2 is the latest version. It measures the anterior corneal curvature indices, pachymetry, focal elevations, depressions on a computer-generated best fit sphere. So this is an example of a OpScan image. You can see that the anterior elevation, posterior elevation, curvature map, and the pachymetry. When you screen, these are the cutoff values which you have to remember. The mean keratometry more than 46.95, inferior superior asymmetry more than 1.2. The posterior float more than 42 microns, a difference between a difference of 50 microns, and the irregularity, any irregularity in the central 3 to 5 mm should be suspicious. And distance of the corneal apex and the thinnest location shift more than 0.9 millimeter should be suspicious. Any thinnest point less than 470 also should be a suspicious value. So Pentacam, the most modern one, which is based on the seam flux imaging. As you all know that the object plane, the film plane and the picture plane coincides at a single point of intersection, which gives an advanced imaging modality. So you can see that there is the first quad map. You can see the sagittal curvature map. Then you have the pachymetry map, elevation map, anterior as well as a posterior. So in the sagittal curvature map, you have to look at the keratometric value where there is steepening or not, and the simulated K values, which is less than 47.2 is a normal value, more than 47.2 should ring a bell. It is a case of suspicious keratoconus. And there is skewing of the radial axis, which is if it is more than 22 degrees should be a suspicious case of keratoconus. And the inferior superior asymmetry, especially the steepening in the inferior part, should be suspicious. If it is less than 0.8 or if it is more than 1.2 or 1.9, you can say it is suspicious of keratoconus. Thickness map, as such you cannot say that only thinning is not suggestive of keratoconus, but the shift of the thinnest location as well as the thinnest point from the apex more than 10 micron is suspicious of keratoconus, as well as thinning along with steepening is diagnosis of keratoconus. And Amsler Krumich have staged keratoconus based on the steepening, myopia as well as astigmatism, and whether there is corneal scarring or not. In stage 1 there is myopic astigmatism less than 5 and eccentric steepening. In stage 4 you will get keratoconus scarring, central corneal scarring along with a thin cornea of 200 micron. So any of the criteria, if it justifies, it falls into that category or stage of keratoconus. Elevation maps, in the anterior elevation map, if it is more than 15 micron, it is suggestive of keratoconus, and normal value should be less than 12 micron. And posterior elevation value, if it is more than 20, is suggestive of keratoconus, and less than 17 is normal, and 18 to 20 is a borderline case or suspicious case of keratoconus. Any difference between back and front surface with plus 5 micron also is suggestive. Next, Bellin-Ambrosi enhanced display. Here the best fit sphere is being made by excluding the central 3 mm point around the thinnest location. So it gives a D value. D value comprises of 5 parameters: the front value, back value, pachymetric progression, thinnest point, and the shift of the thinnest location from the apex. So D value, total D value, if it is less than 1.7 is normal. Anything more than 2 you should suspect keratoconus. If it is more than 2.6, it comes in the red value, it is indicative of keratoconus. As you can see, it is color coded, so anything in the yellow or red should be suspicious or clinically diagnostic of keratoconus. Next, Bellin described the ABCD grading system, where the anterior corneal curvature, back surface, corneal thickness, as well as the corrected distance, visual acuity were taken into account. Here also you can stage from 0 to stage 5 based on these parameters. And next would be a percentage tissue increase in normal cornea from the central to the periphery. There is a uniform thickness happening from the center to the periphery, or as you progress from the periphery to the center, there is progressive thinning. So apex should be the thinnest. It has to fall in the 2 standard deviation of this graph. So first would be it has to come in the central value. Any steep or any abrupt changes should be suspicious of keratoconus. So we have the advanced modalities. You have the Pentacam HR, Pentacam AXL, Cassini, Galili, and Cirrus. The first two are based on the Schimflug imaging. Cassini is based on color LED topography. Galili has dual Schimflug along with Placido based the classical topography along with Schimflug. And Cirrus has single Schimflug plus Placido disk. Cassini is based on the ray tracing. In the Cassini, we have a Cassini report like in Pentacam. Galili, what you have to remember is irregular astigmatism index of more than 0.45 or a standard deviation more than 1.065 or a surface irregularity index more than 0.735 is diagnostic of keratoconus. Cirrus also gives a report like in Pentacam. You can see here what you get a keratoconus. Finally, you have a diagnostic report also, whether it's keratoconus compatible or if it's a borderline topo or a normal topo. But you have to be cautious in interpreting this just value. You have to go to all the maps, whether it's a proper keratoconus also, okay, because sometimes you can have a fallacy or a error report in these cases where there is thinning but no steepening or anything. And next is epithelial mapping. In a normal patient, you have a donut sign which you can see, that is in the central area where there is thinning, there can be epithelial hypertrophy which can get masked in a case of keratoconus. So this is also important in case of keratoconus to diagnose. As you can see, there is a thin area where you can see a paracentral area with a epithelial hypertrophy. So this may unmask in a case with a anterior segment tomography. And Corvus ST, finally, it gives a biomechanical index where there is deformation with a puff of air. So biomechanical properties like CBI, the Corvus biomechanical index, tomographic biomechanical index, as well as the Pentacam bad display also will be there. Any value of CBI more than 0.5 is suggestive of keratoconus, or TBI value more than 0.75 is diagnostic of keratoconus. Bad display, as I said, it is more than 1.6 is suspicious. And it gives a Vincigora report also. So the advanced modalities would be a polarizing sensitive OCT, then in vivo confocal microscopy, brilliant light microscopy, atomic force microscopy, optical coherence elastography. So these are the advanced modality which are still in research. And we have the molecular diagnosis, the tear film proteomic biomarkers, AI, as well as genetic or polygenetic risk factor analysis. So these are the future of keratoconus diagnosis. To conclude, I would say that the innovative diagnosis should include a combination of multiple imaging tools to enhance the detection, not just by a single topography or a tomography. So basic, you should have a tomography, topography, Schimflug imaging, and ASOCT. And other things which I have mentioned are the future directions which we need to work upon. Okay. Thank you.
Very good afternoon to all. I'll be talking regarding collagen cross-linking. So this is the study by Theo Seeler and Sproul, which was published in 1997. It was a landmark paper which introduced collagen cross-linking as a treatment for keratoconus. Since then, the treatment of keratoconus has never been the same, but still it is the gold standard treatment to arrest the progression of corneal ectatic conditions. it uses riboflavin and a photosensitizer that is to peak the absorption at 370 nanometer. It actually uses riboflavin and UVA to produce photopolymerization using free radicals, which will increase the intrafibrillar and interfibrillar covalent bonds. The primary purpose of cross-linking is to halt the progression of the disease. Likewise, the best candidate is an individual with a progressive disease of cornea. And the most common indications are keratoconus, then pellucid marginal degeneration, Terence marginal degeneration, post-refractive surgery, ectasia. There is no definitive criteria for progression, but parameters to consider are change in refraction, uncorrected visual acuity, Baxter corrected visual acuity, and corneal shape on topography and tomography. Contraindications are for the standard protocol is less than 400 microns, prior herpetic infection, any concurrent infection, corneal scarring or opacification, history of poor wound healing, severe ocular surface disease, autoimmune disorders, pregnancy, breastfeeding, and very young patients. So the conventional CXL is the distance protocol, which is done under topical anesthesia, removal of central 7 to 9 millimeter of epithelium with application of 0.1% riboflavin, phosphate, and 20% dextran solution every 5 minutes for 30 minutes, followed by irradiation of UVA for 30 minutes and topical antibiotic with bandage contact lens. So the other protocols after the distant protocol came to decrease the amount of time while keeping the same effect, that is accelerated cross-linking, transepithelial, pulse cross-linking, customized cross-linking, adapted fluence cross-linking, and iontophoresis mediated cross-linking. Accelerated cross-linking based on the photochemical effect of irradiation is proportional to total energy delivered, irrespective of the intensity and total time of delivery. Accelerated cross-linking has found to be safe in stem studies, but it's practically found not to be as effective as the conventional normal CXL. So these are the different riboflavin concentrations and fluences used for accelerated cross-linking. And different studies have shown that 10-minute protocol is better than 5-minute protocol, but the rest of the parameters not much of significant difference. Both accelerated and standard are effective in stabilizing keratoconus, but better visual acuity and K values are with standard protocol. The other strategies are pulse cross-linking, which is based on the fact that the oxygen depletes 20 seconds into the initiation of treatment. So pulse delivery of UVA allows some amount of reoxygenation, thus better cross-linking. And customized cross-linking to concentric, which gives better surface normalization and not much significant increase in haze. And adapted fluence cross-linking, in which the energy is changed to give the customization. So the transepithelial cross-linking is basically done for thinner corneas, but the presence of epithelium may hinder the absorption of riboflavin. But it will the permeability of the riboflavin need to be increased by either chemical enhancers or superficial epithelial scraping, mechanical epithelial disruptors, or stromal channels or flaps. So these are the basic two techniques: the epithelium off and epithelial transepithelial. The epithelial off is the gold standard, but has more postoperative pain and discomfort, higher rate of postoperative possibility of infections, traumal haze is more, and decreased vision in initial postoperative weeks, but better efficacy in halting ectasia progression. So, the efficacy of transepithelial CXL as a treatment is studied in different studies, in which the oxygen enhanced transepithelial CXL being the most effective and comparable to standard epithelium of CXL. So this is the newer edition which is supposed to come in 2026. This is EpiSmart or Epi-on cross-linking resulted in the mean improvement of uncorrected and best corrected visual acuity with an excellent safety and efficacy profile in subjects with keratoconus with few significant side effects. This is an incision-free topical drug therapy for keratoconus. This represents a novel and groundbreaking therapy for patients of keratoconus. So iontophoresis assisted CXL is like a electrode is used to drive the riboflavin into the cornea by giving an electrical gradient. It's done for 5 minutes, and then the UVA is applied. So the effectivity is like the EP of CXL is the most effective, then iontophoretic, then the transepithelial cross-linking. So CXL in thin corneas, the modifications are the hypoosmolar riboflavin is used to swell the cornea, and then more than 400 microns, and then UVA is applied. And CXL with custom epithelial debridement, that is central part of the cornea is debrided and the peripheral part is kept so that the more lesser endothelial toxicity. Contact lens assisted is the contact lens is soaked with riboflavin, and it's without a UVA barrier, so it will swell the cornea into a thicker cornea, and then you can use the UVA in thin corneas. Smile assisted uses a lenticule over the scraped cornea, and then CXL is done. This is also for thin corneas. Adapted fluence already I have told. So these are the modalities which are being used. So with hyperosmolar riboflavin, which is found to be free of endothelial toxicity in corneas less than 330 microns, that may not be effective. And transepithelial, the shallow demarcation line less effective, and contact lens all have their own limitations, the gold standard still being the distance protocol. So it can be combined with vision correction, with LASIK, with phakic IOLs, and photorefractive keratectomy and retrocorneal ring segments to give visual improvement also along with the collagen cross-linking. These are the different vision enhancing procedures that is possible with it can be combined with CXL. It can be done as two separate sessions, but simultaneous approach is found to be more effective. So to conclude, collagen cross-linking is an FDA approved in 2016 single most effective way to halt the progression of keratoconus. The risk of CXL are substantially fewer than the risk of transplantation. Studies of different techniques including Epi-on treatment, changes in UV light parameters, and riboflavin composition continue to proceed with the hope of improving the safety and efficacy of the procedure. Thank you.
So I'll just take on from where the earlier speakers have very nicely elaborated on all the management modalities of keratoconus. I'm going to talk to you of what we do in keratoconus beyond glasses and contact lenses, with particular focus on something new which has come in, where we are moving on from tissue replacement to tissue addition keratoplasty, that is lenticule addition keratoplasty, no financial interest. So I think we have now learned there are various options which are applicable to the management of keratoconus depending upon the stage, depending upon the particular complications which they present with. And this particular chart is something which all of you would have seen in many presentations and the table and textbooks here. So I'll talk to you on what are the other concerns which you would have here. So concerns in collagen cross-linking, be it adult or pediatric, is infectious keratitis. So that's the one concern which one needs to understand, especially when you are looking at epi of collagen cross-linking. So this is a management modality. This is an infection which you need to differentiate from an infectious or an immune condition in such patients. Next is the management of hydrops in patients with corneal ectasias, be it keratoconus or be it pellucid marginal degenerations. We have the conventional management modalities, being medical management with hypertonic saline, steroids, antibiotics, manage the pressure here. And we also intracameral air and intracameral gas injections here. But what's new on this in this aspect, with consideration that intracameral gas injections for treating eye drops can result with pupillary block glaucomas, as we had in one of our cases here. What's new is that we now do a combined modality of compressive sutures or special compressive sutures placements along with intracameral air injection and contact lenses, and this alleviating the need to use gas and the complications which can arise along with that here. Moving on to those cases which need keratoplasty for their visual rehabilitation beyond the stages where the glasses and contact lenses are not helpful for them, or those who do not want to wear contact lenses, penetrating keratoplasty is limited to those cases. Now I think most of us do not any longer do penetrating keratoplasties for our ectasias, especially only in very advanced cases and where you have a significant amount of corneal thinning is when we are probably going to do keratoplasty for these cases here. So the risk for keratoplasty complications, the graft rejections are all going to end post-PK astigmatisms do remain with these cases here. And most of us have now moved to do deep anterior lamellar keratoplasties for those cases which are not amenable to contact lens rehabilitation. But please do remember the complications induced by suture-induced vascularization, suture loosening, post-DALK astigmatism management, and of course rejection also can occur in these cases, as you can see in this picture out here, because of loose sutures with the patient was not on regular follow-up long-term. Yes, so those are management modalities which you need to look at when you are managing these patients. So serial anterior segment OCT scan, especially in those who undergo deep anterior lamellar keratoplasties, is desirable to identify early rejections, because you can reverse these rejections fast when picked up with topical steroid therapies only here. Of course, this is one video where I'm doing a deep anterior lamellar keratoplasty for a pediatric keratoconus patient. It's a Desmet's bearing or a D-DALK procedure here, as you can see. If you have an IOCT, it's not that you cannot do it without an IOCT, but if you have an IOCT, it really helps you to look at and see the various layers in which the air is percolating. That's the brave slash out there, and you can see the Desmet's fall back into its position here. And you can fill the chamber with viscoelastic before you go ahead to do the dissection of the roof of the big bubble chamber here. So much of it is then it's pretty simple after you've achieved here, but not to worry if you are not able to achieve a big bubble DALK. You could always also do a manual DALK in many patients, because most of these studies long term do say that the differences when you look at them long term is not different in terms of the visual rehabilitation in these patients. So moving on from looking at the need for doing intralamellar due to do tissue replacement keratoplasties, we are now including into our armamentarium armamentarium of management modalities, intrastromal keratoplasties here, which comprises of making of an intrastromal channel, which could be manual or which could be made by a femtosecond laser. And in this lamellar channel, we inject the lenticule, which is fashioned out by an automated lamellar microkeratome here. So that it's been there for quite a while, but we had not adopted it earlier, and now we see a need to adopt this more in our cases, because probably in those cases which have gone thinner are not suitable for collagen cross-linking, or which needed aided collagen cross-linking. You can use this as an added modality here. So this is a keratoconus cornea which is being docked on a Visumax, no financial interest here, and you will need to make particular alterations in your machine parameters, because docking on a keratoconic and thin corneas will need alterations into the data fed into the machine here. And this is a case of chronic VKC, not amenable to contact lens where also a patient could not wear it. So we went in and created a lamellar channel for these patients here, and this is the donor lenticule being fashioned after the epithelium is removed. The donor anterior lenticule, comprising of Bowman's layer and stroma, is being fashioned out, and from that an 8.5 or 8.5 lenticule is fashioned out. You go back to the host cornea, it's taken into the main OT. Patient is taken into the main OT, and there you can see the incision is now, the lamellar dissection made is just being opened up by a blunt lamellar dissector here. So this is a pretty simple invasive technique compared to a keratoplasty technique, but what's important in this is you need to know the kind of cases which will be amenable to visual acuity improvement following this particular procedure. So that's the lamellar channel, femtosecond dissected lamellar channel, which is being opened up in the host cornea. We use, this is a Visumax used with the PI of a different, a medium sized PI here. And now the lenticule, which is fashioned out, is inserted into the lamellar dissection, which is done. You could see it's a pretty much simple procedure here, but you do need to have caution in terms of choosing the right patients in order to afford improvement in visual acuity in these cases here. Subsequent to this, you know, now the tissues become thickened, and it will be amenable to collagen cross-linking, the conventional accelerated protocol here. So epithelium is then taken off, and you can see after alcohol treatment, the epithelium is removed, and the cornea undergoes the routine accelerated collagen cross-linking procedure here. So this is one way, and we are now looking at the results of 10 of our cases who underwent this procedure as a pilot study. And now we have data over 2 years on that, the prospective data of over 2 years of these patients. And you can see when they're being followed up to 6 months, I can see your photographs here. The lenticule becomes comprehensive, compacted here, and their unaided visual acuity increases in about at least 80% of the patients whom we operated, and the cone stabilizes as well here. So this is one other, this is again the same procedure being done in another patient here. I'll just fast forward for you. The lamellar dissection done is being opened up again with the dissector, and the lenticule is inserted here. So it's pretty much a similar procedure, and you could see an intraoperative OCT which helps you to see it. This is alcohol assisted epithelial removal here, and then the lenticule which is fashioned is inserted, and collagen cross-linking completed here for these cases of progressive keratoconus here. So that's one other modality, and you could see how the topography changes in these patients with the amount of flattening being induced in these patients when you look at them from month 1 to month 6 here. And many of them do have improved visual acuity with their spectacles itself here. So structural stability is something which can be afforded by this procedure here. Corneal flattening both in the steeper meridians and the flatter meridian, the Kmax also flattens in these patients. The biomechanical strength, not all parameters increase with Corvus, but some of them do show a change here. The visual acuity, we could see that in most of our patients there was a statistical significant improvement from their unaided visual acuities, and their spectacle acuities also improve. But the corneal aberration does not show much of a change. But if you ask me, if you compare it vis-a-vis doing a deep anterior lamellar DALK, of course the vision quality is much better when you do a DALK, because there's only a single interface when you do a DALK. But when you put in a lenticule keratoplasty, there are 2 interfaces here, and that's definitely going to compromise the quality of vision which you would would have in these patients. That is the downside to it here. But we are looking at those patients. It's an interim procedure where you can offer it for those who do not want to do keratoplasties, and for whom you could probably stabilize the corneas along with the procedure and also bring out a refractive change in these corneas. So that's where it currently stands here, and thank you for your kind attention. This is our team out there in RP Center, AIMS, New Delhi, who all participated in this trial here. Thank you so much.
Good afternoon, everyone. So after all these talks, we can understand that keratoconus is a dynamic disease. Even the risk factors, etiology, pathophysiology, treatment modality, diagnostic modality, everything is undergoing an evolution, and there is still scope of improvement in each and every area in this particular disease. So there is a rising trend in keratoconus that we can even see in our OPD. There is more of keratoconus patients, keratoconus suspects, pediatric keratoconus suspect, keratometry suspicion in pediatric patients. All this is going on a rise, and the highest incidence was noted from the year 2015 to 2019, and post 2020 there is a higher prevalence of keratoconus in the global population. So what we know about the pathophysiology, we know that the etiology is multifactorial. Both genetics and environmental factors play a role. Even family inheritance has a role. There is association with syndromes. Even the environmental factors like atopy, allergic conjunctivitis, eye rubbing. Now even the research is happening on whether rubbing with your knuckle, with your hand, even rubbing frequency or intensity, what is causing an increase in keratoconus, all these factors, even the risk factors are undergoing so many studies as to correctly define what is more risk to the cornea, whether it is eye rubbing as such, frequency, intensity, etc. And also allergy is on a rise. Consequently, in children also there is a rise in VKC, and keratometry values also are also showing in the steeper side hence. There is myomechanical failure in the cornea which is happening. There is an increase in oxidative stress. The antioxidant levels are reduced. The corneal strength is broken because of the collagen matrix protein which is getting deranged due to eye rubbing or mechanical stress, and also adding on to it is the genetic predisposition factors. So still we have not understood the exact mechanism going on in a keratoconic cornea. So the research in that field is also going on. Basically, we need targets where we can have medical treatments to hold those pathophysiological changes. If there is a deficiency of antioxidant, can giving some antioxidant cause a progression reduction in keratoconic patients? The genetic studies are mainly being focusing on polygenic risk scores, and combining this polygenic risk score with a patient history or risk factors can assess. We can particularly tell that this patient may progress to keratoconus and this patient will not progress to keratoconus. So the near term goal will be to integrate these genetic scores with tomography biomechanics to stratify progression risk. There is a few of the studies have shown that acetylcysteine, which is an antioxidant, can be a potential treatment. That is also an area where the studies are going on. Various genes have been implicated, and further research, we need to know which all genes need to be included in a screening panel for keratoconus, which group of patients should we use this screening panel. So one of such screening panel is the AvaGen, Avellino Lab, USA. Just a buccal swab is taken from a suspected patient. It is a panel of 75 genes, and in suspected patients or family history of keratoconus, but it is not available in India. So that is about the risk factors and genetic basis. Now coming on to the diagnosis, we have most modern imaging technologies, but what else do we need? Fourier domain OCTs, corneal biomechanics. It has been shown in studies that Corvis or ocular surface analyzers can show you changes in the biomechanical indices early on itself. So even before the topography detects a change in your cornea, if you analyze the biomechanics with Corvis, you might be able to detect at-risk corneas. We still doesn't have a criteria of progression, like this is progression in this patient. A universal protocol for definition of progression is not there, so each institute have their own way of detecting progression. Some people detect it at 3 months, 6 months, one diopter change in keratometry. So mainly we are looking for a change. So a universal criteria is still not, the heterogeneity of this progression definition itself is an area of research. So in the pipeline, we will have AI models on multimodal data. So AI models should come, which will take into account all these data, topographic, tomography, biomechanical, also the demography of the patient, family history, if any. All these should be analyzed together to give us a risk score or something which will tell us that probability of this patient going on to keratoconus is high, low, or in what is the risk of that particular patient getting this disease. Then in vivo biomechanics, including brilliant microscopy and OCT elastography, is also a potential for treatment planning. We'll be able to analyze the cornea with motion, what is the changes happening in a cornea. Then what another research is happening is how we can monitor this eye rubbing or self-administered topographic techniques, how patient can from the home itself change or detect if any changes is happening in his corneal parameters. So these areas are also being explored. So this is motion tracking brilliant microscopy. So it can effectively characterize and tell you that focal areas wherever there is weakening. So that is a new research which is happening. The multimodal machine learning systems integrating parameters from Corvis, tomography and biomechanics. All these will help in early keratoconus detection. So now, rather than treating a patient with keratoconus, our full focus is on detecting patients early on, avoiding refractive surgeries or doing better refractive surgeries in those patients who are at risk for going on to a keratoconic cornea. This is Smart KC, which is a device to track eye rubbing in patients, which was also in a trial. Nothing has been come out to the market. Then there are biomarkers in tear fluid. So you can get tear fluid analysis done for interleukin 1 beta, galactin 1, galactin 3. All these can detect early keratoconus. So the values for these can be fed into a machine, and then by associated risk factors can be added. That also can give you data on early detection of keratoconus. So few concentrations of MMP9, interleukin 6, receptor for advanced glycation end products. All these in tear fluids the studies have shown that all this will give you an idea of the patient is at risk for keratoconus, or if already values are very high, chances of keratoconus is high. In therapeutics wise, the gold standard for preventing progression still remains the epithelium off, but epithelium off technique has its disadvantages, infectious keratitis being the most dreaded one. So we have to find solutions to overcome this. So epi-on techniques are being investigated. And in other than that, vision, how can we improve? Contact lenses, advanced contact lenses are coming. Then we are combining CXL with vision correcting procedures like PRK, intracorneal ring segments. For advanced diseases, still our resort is DALK or PK. Recently we have additive procedures like KSOS and intralenticular implantation of stromal lenticle or smile lenticule. Delaying graft. We want our young patients to not go into a keratoplasty kind of situation. That has become the major objective. CXL innovations, we brought about the accelerated protocols, but we still don't know if they are equally efficient, because many studies show equal efficiency, but there are few studies which also show that the standard protocol is still the best. Transepithelial CXL with enhancers, there are many newer ones coming up. Pediatric KC, that is an area where we still need to progress in research. We don't faster progression even with CXL, that is not halting. Pediatric specific protocols need to come so that we can halt progression in pediatric patients. in treatment, there are drug-based therapy. There is one drug which is under FDA phase 3 trials, that is IV Med 80. It is a copper sulfate drops that is under study. So basically this lysyl oxidase enzyme activity is found to be low in keratoconus patients. So copper acts as a catalyst for that particular reaction. So naturally improving cross-linking in the cornea is what we are aiming at. Then to enhance the CXL with Epi-on procedure, there is Epi-Smart, in which sodium iodide is added with the riboflavin solution, so that that penetration less is due to the epithelium. Sodium iodide acts as an enhancer and better penetration happens. So this is also under FDA phase 3 trials. Epioxa is also a modified riboflavin, but this has been approved by FDA now in October. So this is a modified riboflavin with Epi-on. If we put this riboflavin, it will have better penetration, and this kind of epithelium on CXL is getting FDA approval, and we might be age above 13 years is eligible. So this might be coming into the market soon. There are CXL contact lens also. All these are in trial only. Rose Bengal assisted CXL, that is also cross-linked stroma, anterior 100 to 120 microns of the cornea without any toxicity. We are able to, that is also under study. We have to further study and find if oxygen plus Rose Bengal can be an effective alternative to riboflavin. Then there is CXL innovations like customized CXL, where we have to customize and give UVA to particular areas in different energies. CXL with photorefractive, intrastromal, all these are under study. Surgical frontiers, we have Bowman layer inlay or onlay transplantation, intracorneal ring segment with CXL, then regenerative approaches wherein stromal tissue engineered. Stem cells are being injected into the stroma so that we want more stromal cells to come and increase the stromal thickness. Artificial cornea is being made, which can be an alternative to the global shortage of cornea tissue for transplantation. The minimally invasive keratoplasty techniques like Bowman layer transplantation, femtosecond laser assisted intrastromal implantation. The Bowman layer transplantation as well as both these techniques have been found to be an option to treat advanced cases. So they will stabilize the ectasia is what studies have been found to have. Additive keratoplasty procedures like KSOS, corneal allogenic intrastromal ring segments, are being implanted into the cornea so that the astigmatism and stabilization of corneal tissue happens, is another area where research is happening. So in customized KSOS, it has been found that there has been significant flattening, changes in K1, K2 and Kmax with the procedure. Also improvement in visual acuity and reduction of higher order aberrations have been noted in studies. In lenticule assisted implantation of lenticule also, there is found that the visual acuity improves, cornea stabilizes is what studies have found. What are the key gaps? We need a standard protocol for progression assessment. We need RCTs where we will find out where accelerated is transepithelial versus standard, which is the best protocol. What can we do for as medical treatment to modulate matrix remodeling, which is the underlying pathology. Stromal regeneration strategies, rigorous evaluation is needed on that side also. Our take-home message is that detect earlier, personalize the treatment, multimodal AI plus biomechanics to identify fast progressors, early detection. CXL remains the cornerstone for now. Which all patients need to be selected for accelerated Epi-on customized protocols, that we will find out eventually with the research. So the future is always going to be biomechanically guided reinforcement and stromal regeneration, or whatever treatment which can help us delay or avoid transplantation in these patients. Thank you. We have 5 minutes. 5 minutes.